Oncology second section, prostate cancer. 3, 2, 1. Prostate cancer is a much simpler section than breast cancer because there's less that you can do about it. See, prostate cancer, first of all, we don't have any good screening. The PSA is crappy screening. You see, the PSA does not lower mortality. The PSA does not lower mortality. Mammography does lower mortality. The PSA is not a great test because if the PSA is elevated, and then we go in and we say, oh, I want to use the digital rectal examination to tell me if there's a lesion that I find, digital rectal exam, I can biopsy that lesion. But what if the digital rectal exam is negative? Well, then I need a transrectal ultrasound to be able to tell me, hey, if there's a lesion on the transrectal ultrasound, I'm going to biopsy that lesion. But what if the transrectal ultrasound is negative? This is the point that most people don't understand about PSA. The point that most people don't understand about the PSA is that if you have an elevated prostate-specific antigen and you can't feel a lesion and you can't see it with the transrectal ultrasound, you still need to go in and do multiple blind biopsies. Multiple, just go right up there and do 12 blind biopsies and try and find that cancer. 12 blind biopsies. 12 blind biopsies. See how they run right up your ass. The needle's up your backside. I can't tell which side. 12 blind biopsies. 12 blind biopsies. Wow, man, no wonder people bleed and get infected from this thing. Because it means that no matter what happens, the elevated prostate-specific antigen leads to a biopsy, even though it doesn't lower mortality. 25% of people with an elevated prostate-specific antigen have no cancer. 25% of people who have cancer have a normal PSA. And that's why this is a crappy test. If this test was invented now, it wouldn't be called prostate-specific antigen. It'd be called like prostate-suggestive antigen. It's not good. So prostate-specific antigen is not good because whereas in breast cancer, you have a lumpectomy and radiation, there's no lumpectomy for the prostate. For the prostate, there's only a radical prostatectomy, radical removal of the whole entire prostate. And that's why. Next, breast cancer has chemotherapy that can be used if the lesion is above 1 centimeter or metastatic to your lymph nodes. There is no good chemotherapy for prostate cancer. Nothing first line, maybe some things that you could do if radiation doesn't work. Next, in breast cancer, you have trastuzumab, anti-HER2 antibodies. There is no equivalent of anti-HER2 antibodies in prostate cancer. There's no antibodies to be able to get rid of prostate cancer. In breast cancer, you have selective estrogen receptor modifiers and aromatase inhibitors that prevent metastasis. Oh, this is very hard to understand in prostate cancer. There is no hormonal therapy to prevent metastasis of prostate cancer. There's only hormonal therapy that shrinks prostate cancer once it's already occurred. So drugs like flutamide, bicalutamide, nilutamide, the testosterone receptor blockers, they don't prevent metastasis. They shrink metastasis that have already occurred. There's ketoconazole or an orchiectomy that shrink metastasis once they've occurred, but they don't prevent metastasis. There's ketoconazole, which is anti-androgenic. Ketoconazole, which is anti-androgenic, that shrinks metastasis, but doesn't prevent metastasis. We're not using a lot of ketoconazole anymore. No, there's degarelix, which inhibits gonadotropin releasing hormone, but it doesn't prevent metastasis. It shrinks metastasis once they've occurred. And this is the single biggest difference between prostate cancer and breast cancer. Breast cancer, you have surgery which prevents metastasis, hormones manipulation which prevents metastasis, you have monoclonal antibodies that prevent metastasis, you have chemotherapy that prevents metastasis, and prostate cancer, what do you have? You basically have surgery versus radiation therapy, and it's not clear which of them is better. Surgical therapy is probably a little bit better. If you are young, meaning under 40-50, under 50-60, under 40-50, under 50-60, and you have a high Gleason scoring is a measure of the aggressiveness of that lesion, you should probably get surgery to remove that lesion. If you're older, meaning that you're above the age of 70 and 80, and you have a low Gleason score, you should get radiation therapy because the surgery is not going to provide a survival benefit. Gleason scoring is useful because Gleason scoring can give you a measure of how aggressive your prostate cancer is. If your prostate cancer is very aggressive, if I had one with a high Gleason scoring, I'd get my prostate taken out. I would. Even though I'm not crazy about that idea, I don't want the incontinence and the erectile dysfunction, because that's what happens with the surgery. You get incontinence, urinary incontinence, and erectile dysfunction. I'm not crazy about that, but it's better than being dead. Gleason scoring tells you the aggressiveness of disease. Young with a high Gleason score, surgical removal. Older with a low Gleason score, don't remove it. And in the middle, I can't tell you. But look at the huge difference between breast and prostate cancer. Isn't that enormous? I wish there was something more we can do about it. I do. But there isn't at this time. I'm sorry about that.